thank you so much, Andy. Just for everybody's knowledge, just to introduce myself, I'm Aaron Martin, Chief Digital Officer for Providence St. Joseph Health. And we have Andy Slavitt here, who's a former CMS commissioner and administrator. And thank you so much for taking the time to talk with us.
Great to be here. Thank you.
And we've been discussing a lot about Medicaid over the past couple of days, and would love to just get a sense from you as to where you think things are headed with Medicaid from a funding and programmatic standpoint, given the policy environment.
Sure. Let's spend a second on what Medicaid is and what it does.
Great.
To remind everybody. Medicaid really serves four populations. It serves kids, and in fact, about half the kids in the country and half the births in the country are paid for by Medicaid. So really important when we talk about having a great start to life. We are going to have either a great start to life for the kids in this country because of Medicaid, or we're not if we don't do that well. And that's one of the wonderful things about the program. Second population it takes care of are people who are living with disabilities. In fact, it may surprise a lot of people to know that 40% of the program, 40% of the dollars in the program go to care for people living with disabilities. These are often middle-income people who, but for Medicaid, would fall out of the middle class. And it's their lifeblood. That's how they get to stay at home. That's how they get to keep their kids at home. The third population are elderly people. So half the nursing home care in the country is paid for by Medicaid. So statistically, one of us is going to have our nursing home care paid for by Medicaid.
Yep.
And that's of critical importance to the program. And then it really acts as a program for people who are lower income or very, very modest incomes, as they are, again, with healthcare being one of the most things that causes the most financial insecurity, helps it to get there. So, with that as a backdrop, it is a big line item for a lot of governors, and it's often 30% or so of a state budget, and so there I think has been a big federal question about whether or not and how to continue to fund Medicaid. I think many of us would argue that it's a really efficient program. It's about 30% less costly than commercial insurance and much less expensive than Medicare. One of the reasons is because it reimburses lower, and that's one of the challenges. So the question is, what to do with the program. I think there's been proposals coming out of Washington this year to both reduce funding for the program, as well as to change the structure of the program, to put a cap on it. And we can talk about the merits of those things, but I think the important thing to know is, if you're going to cut the Medicaid program by 25%, as a lot of the repeals bill did, you're going to have to do one thing, one of three things. You're going to either have to cut the number of people on the program by 25%, cut the services by 25%, or cut reimbursements by 25%,
right,
or some combination. And for a very efficient program already, its medical costs are about flat, and whose populations are not populations that can really necessarily do much about their need for Medicaid, I don't think it's a good idea. So it's still on the table. It's still something that I think we'll see part of the president's and Congress's tax budget will have, I think, some pretty significant Medicaid cuts in it, but it's all things I think we should be paying attention to.
Yeah, I think, from Providence St. Joseph's perspective, this is an incredibly important population for us. This is part of our mission, and I think one of the things that's a little bit frustrating from a policy standpoint is we've seen much heavier adoption of getting more people kind of care. So that is working. And the fear is that whether this be, kind of a long-term cut or a temporary cut, we'll end up starting over again. Because I think, if you talk to clinicians anecdotally and caregivers across our health system, what they would say is they're seeing people earlier in like a disease status than they did before. Whereas before, we would see them in the ED almost all the time. Or there's a disease state so advanced that there was nothing.
You're saying before and after Medicaid expansion?
Correct. Yeah. And so we're in, I think, 5 Medicaid expansion states, 3 of the biggest ones. And so, the fear is that we're seeing a bolus of cost now, right? But that's because a lot of people are receiving care that they didn't have before. And then if it gets cut off, we're going to start that whole cycle again down the road, or we're just going to see what happened before, which is, people with incredibly,
Right.
Both extended disease states as well as expensive too.
Right. Well, you make a great point. The costs don't go away. I mean, if you cut $1 trillion from Medicaid,
it goes somewhere.
Right. It's not like people don't need the care.
Yeah.
It's not like people are not going to spend the care. And what will happen, of course, is they'll just consume it differently.
Yes.
As you point out, they'll consume it later in their disease state. When they feel a lump, they'll say, well, maybe this will go away because I sure as heck can't afford a mammogram.
Exactly.
Now, under the Medicaid program, women can go get their free preventive care, and you can catch these things at the early stage. And God, what a difference that makes in someone's life. But also, the money will come right back at you, and it'll come in a variety of forms, as you all well know. Your bad debt will start going up. Even worse, people in the community will start to have more personal bankruptcies.
Yep.
They'll be less healthy. So it's really not a wise investment, in my view, to skimp here. And there's just no precedent anywhere around the world for cutting care and services to people who need them and having it pay off.
Yeah. I grew up in an economist household, and the thing that my dad always used to say is there's no free lunch, right? And so there's no avoiding a cost burden. There's ways of making it smaller by getting ahead of it. And you see this in any other industry. It's especially true in healthcare.
Right. Well, and that's the exciting thing is we put that aside and start focusing on innovation you can bring to this population and to these folks. It's the sky's the limit because we really haven't. We've sort of many of these populations have been, as you and I have talked about before, Aaron, been left on the side from a lot of the exciting innovation that really can occur in this space.
Well, let's talk about that. So my team, we're starting to dig into, can we use technology to better serve the Medicaid population, the poor and vulnerable. And I have to tell you, the team here in Seattle in digital, I've never seen a group of people more kind of engaged and enthusiastic about, a mission. And, to give, some folks some kind of context, a lot of my team comes out of technology, so the usual suspects, Amazon, Microsoft, Salesforce, places like that. And the reason why they came here is because they wanted to kind of, have an impact and, have a change and something meaningful, myself included. They're super excited about it, but we'd love to get your perspective on kind of where do you think the opportunities for innovation are out there and some examples in the Medicaid population.
God, that just gave me a little bit of the chills just thinking about something people don't really think about very often is, the impact of our work on the workforce when they see that we can really move the needle.
Yeah.
And, with these populations, you've got some incredibly measurable things that for people who are, technology folks and who, don't want to be pushing, 75 strings up the hill and not seeing what happens, which is what happens in healthcare sometimes.
Yeah.
The ability to say, okay, we know that take, for example, moms, which is an area where Providence St. Joseph is very focused, pregnant moms. If babies aren't carried full to term, you'll end up with babies in the NICU, and which is not a good way to start life.
Yeah.
It's also an incredibly expensive endeavor for the system. Providence St. Joe's is committed to that expense, but Providence St. Joe's getting committed to saying, hey, wait a minute, what are the things we can do upstream?
Yeah.
And a lot of the great work, a lot of the great innovation going on, you start all the way upstream and saying, what can we reduce unwanted pregnancies? Because a lot of time, the teen pregnancy rate, is the first step in the process. Yeah. And we can. As a country, there's programs we can do that. There's innovative things we can do to do that in concert with others in the community. Yeah. Second, can we help someone carry their baby to term? What are the things that are necessary for a healthy pregnancy? And third, if we've got other issues like smoking or drug addiction or things like that, how do we address those during the process? And if all those things lead to this one outcome, which is essentially, and when you look back over the course of the last month and say, guess what, we had fewer babies that spent days in the NICU from the Medicaid program, that's a massive achievement in so many important ways. And the ways to get there really unlock, I think, how we think about providing care, interacting with the community digitally. And it's different than the way hospital systems traditionally operate. It's getting much more involved in people's lives and where they get connected, whether it's the pharmacy, the grocery store, the gym, their neighborhood, the salon, a digital relationship that they might have with somebody that helps them through that. And I think those are the kinds of opportunities that we really have in front of us now.
Yeah, it's interesting. I was meeting with somebody in Chicago, and who's an expert on the Medicaid population and preterm births, and I asked her, like, what is the number one thing? If you could change one thing, one metric about, that would kind of result in a better outcome, and she said, getting them to the appointments. She said it's easy to say, hard to do, right? Because then you start peeling back, why is she not showing up, right? And there's all kinds of social determinants and things like that kind of weigh in on that. So talk a little bit about, when you're running Medicare and Medicaid, it's that program, but there's this kind of entire kind of ecosystem around social determinants that kind of impact all of those populations. And when you and I were talking last night, one of the things that I was thinking about is we tend to tie social determinants to the Medicaid and Medicare population, but it's really not that simple. You can't, if you even look at the commercial population, for instance, it's a continuum, right? Like maybe it impacts them less, but I can think of 20 different things that would impact a middle class person who is commercially insured or is on the exchange or something like that. So, but talk a little bit about social determinants.
So let's start with this.
Yeah.
Let's say that you and I are both diabetics.
Yeah.
Now let's add to this that I have either a nutrition or a housing challenge on top of my diabetes.
Yeah.
Right off the bat, it costs 60% more to treat me than it does to treat you. Now let's add to that I've got a behavioral health challenge. I've got depression or schizophrenia or something of that nature. Now I cost 300% more to treat than you. And then add to that poverty and age. And then I cost about 550% more to treat than you. Now guess what? We both have the same blood sugar.
Yeah.
But it goes to something that you said,
right,
which is that you're much more likely to be taking your medications regularly. You can afford your prescriptions. You're more likely to be hitting your appointments. And I'm much more likely to have, because of the variability of other things in my life, I'm likely to miss those things. So the reason I think it's good to start with the numbers is because the more you treat it like a math problem than an essay problem, the more we're likely to be able to solve it.
Right.
Because it's not a lot of, we don't need to do a lot of kind of inventing new science to figure out how to close that gap. Now, maybe we'll never get me back to the same cost of care that you do. And by the way, along with that cost comes a quality of life. So I use cost as a bit of an index for that. But we will start to realize what other OECD countries have long known, which is, and you said it earlier, there's no free lunch. You're going to spend it one place or you're going to spend it the other place. And the statistic that I think is most important for people to understand is people generally aware that we spend twice as much money as the rest of the world per person on healthcare. What we don't often talk about is that the rest of the world spends twice as much money on social services than we do. And that's a much smaller number. So that investment in housing, in nutrition, in behavioral health, in poverty programs has a very significant payback.
What's great about Providence St. Joe's is the heritage that we've got. We own low-income housing, for instance. We kind of have always been in the social determinants as an organization. And it's what's great about it as an innovator and somebody who loves working on problems like my team does, is everything is kind of on the table, right? So what's cool about this organization is, we won't do it all ourselves, but like the tradition of the sisters, when you hear some of the stories, is they were very solutions oriented. So they would see a problem. And so they would, land in the Pacific Northwest, and how they got into healthcare was there were no hospitals, and so they went out on begging tours, which is the old school way of doing fundraising, I guess, and they would kind of raise money from the local miners and whatnot, and basically just go build a hospital because they needed one, right?
Right.
And then they would go, oh, we need an orphanage, we need this, we need that, and it's that mentality of we're here to solve the problem, not be defined by what
Right.
business we're in or whatever, right?
It's sort of, I think Jeff Bezos was great at saying, if not us, who?
Yeah,
So if we don't do this, it doesn't happen.
right.
And I think, and I've spent the last day here at Providence St. Joseph's talking not only with you and members of your team, but other people across the organization. And that's very much the attitude here, which is this is a challenge, this population and serving this population, it's a challenge that's not going to go away.
Yeah.
And if Providence St. Joe's doesn't tackle it, nobody will.
Yeah.
And I can assure you that that is accurate.
Yeah.
If you don't tackle it, the problem doesn't get better.
Yeah.
And that's at once kind of, on one hand, kind of feels like, oh, well, that's an overwhelming responsibility. Why do we have that responsibility? But on the other hand, as you say, the heritage here is such that that's exactly what you're purpose-built for.
Yeah.
And I think the exciting thing is to combine being purpose-built to deal with these challenges, but doing it in a brand new, modern, innovative way, so that it doesn't feel like a burden and an obligation, but it feels like an exciting opportunity.
Yeah, I think you're absolutely right. So let's talk, you started off talking a little bit about the misperceptions, I guess, or who actually are Medicaid patients. This is something that is, we did a campaign internally and externally during the Medicaid debate about like who actually, I think we called it Faces of Medicaid. Who actually are Medicaid patients. And one of the, I think, misperceptions that I run into all the time is that they're not digitally enabled, that they don't have cell phones, and so on. And couldn't be further from the truth typically, right? I mean, the cost of a cell phone is relatively low, but I think what was inspiring to me about this last debate is people stood up for that population. And I have to tell you, the cynical part of me was very worried about that going into it.
Me too.
And we had, I think, something like 5,000 caregivers reach out to our senators, during that last debate, and advocate on behalf of Medicaid and the poor and vulnerable. So it was really inspirational. But the question I've got for you is how do we change that perception? How do we change that, that other,
the stigma.
The stigma, yeah.
Well, first of all, I think what you said is really important, and I want everybody from your organization that watches this to understand one thing. Providence St. Joe's is not just a leader in your communities. At moments like this, you became national leaders. And the voices of your team members here, excuse me, some coffee might help this. The voices of your team members and the faces of Medicaid, and my frequent conversations with your leadership team about what was going on in Washington really was a leadership moment, because I think it's very easy to step back and watch the way the wind's blowing. And a lot of organizations did that, and you guys did not. And I think that's one of the things I want to thank you for, and I want to thank the rest of the team for, and all of your people. I think the reality is that Medicaid, I think, as it was born as a program that people associated with the welfare program and so forth. And what I think people have to start to do is understand how much they can see themselves and their communities in these programs. I think it does help somewhat that different states brand these programs, their own and differently, and I think that's fine, and I think that's great. Apple Care or Aloha Care or Rainier Care, whatever they have. I think that's all to the good, because I think these are not programs that should stigmatize people. These are fantastic programs, some of the most successful programs, in fact, that we have in the country. And I think it's the personal stories. So, I often will, in talking to people, will make sure to ask people if they've ever been on Medicaid. So first of all, you'd be surprised how many people say yes.
Yeah.
People tend to think that it's a program for people of color. It's not.
Yeah.
In many states, well more than half of the population is white, and in fact, nationally, it's 41% white.
Yeah.
So why does that matter? It shouldn't matter, but it matters that people have to reflect something that they can see themselves in,
Yeah.
and so that you have to give people a reason to identify. And then I think you'd also be surprised at how many people have a story of their sister or their brother or someone in their family. And then if they don't, I think we have to really challenge people to think about is, we all know people who have children with disabilities. We all know people who have parents in nursing homes. And I think being able to connect to someone one-on-one in ways that help them understand, what that program does, which is essentially becomes Faces of Medicaid on steroids.
Yeah.
One-on-one, very one-on-one.
Yeah. So tell me, so recently you did a series of town halls to that point that I found the feedback that you got, really, really fascinating. But talk a little bit about like some of those interactions that you had and the town halls that you did and what you found out and that kind of thing.
Sure. So what I did over the course of the last summer was I traveled around to different parts of the country and met in districts, typically in districts that were both Democrat and Republican, or heavy Republican, although certainly did some in Democratic districts. But the point was to be able to see if we could get people to put politics aside and recognize that the issues we're talking about, up until this point, except for our first question, we haven't been talking about politics.
Yeah.
We've been talking about real life.
Right.
Kitchen table issues, dealing with someone with an illness, how do you pay for it, how do you keep yourself out of bankruptcy?
Yeah.
All the things that are just life, beginning life.
Yeah.
Beginning life healthy.
Yeah.
Going through life, not falling out of the middle class. Ending life with dignity. These are experiences that we all share.
Yeah.
And so going into a room with 500 or 600 people and saying, let's talk about healthcare, and which means we're not going to talk about politics, and allowing people to say, one of us may have voted for President Trump, one of us may not have. We may have strong feelings about that. One of us may have thought President Obama was terrific, and the other one might have thought that President Obama was terrible.
Yeah.
But it's irrelevant.
Yeah.
And getting people to understand that they don't have to declare a political allegiance, and then having a little bit of a conversation about what's going on and what's at stake and how it affects them, and then listening and asking questions. So, and a very ordinary, typical question, one of the sessions I was at, a woman raised her hand, sitting in the front row. She was 30 years old. She stood up and she said, I've got depression. It's a mental illness. And I have been medicated the last 3 years, and I'm doing great. And I'm able to go to work. But the thought of not being on my medication, I can't work.
Yeah.
I can't work. I can't have a family. I can't do anything. And I'm really worried about being able to continue to pay for my medication.
Yeah.
What can you do?
Yeah.
And that's the kind of thing that people hear and understand and can relate to, and it's where the conversations become deeply personal. I think when we look at healthcare through that lens and look at health policy through that lens, the solutions become a whole lot simpler.
Yeah.
Right. We don't do a lot of magical hand waving of great political theory, but we focus on how to address the problems at hand and how to support organizations like Providence St. Joe's in being able to serve people like that.
So the last question, and I think this kind of follows on to it, which is we talked a little bit about from a policy standpoint, how do you take healthcare out of being kind of the football toss between both sides? Because coming from a health system perspective, obviously it's not helpful. It creates risk and uncertainty with how we kind of move forward with the business that we're conducting. If we don't know what shoe is going to drop, based on what election or whatnot. And so it creates a lot of fear, risk, and uncertainty for both our patients, our caregivers. Unnecessarily.
There's plenty of fear, risk, and uncertainty already in the world.
Totally, yeah. Right. I mean, we've got enough to deal with. And how do we get this more to a consensus because the most successful social programs we've had have been consensus driven. So you think Social Security and Medicare. Right. There is no political party that is going to say, you know what, Medicare is not a good thing. Right. So.
Right.
Yeah.
You just asked, I think, the most important existential question we have now as a country.
Yeah.
Right now, which is how do we rescue ourselves from this situation we're in? And everybody has their hands dirty on how we got here.
Yeah.
But the real reality is, unless we find our way out, we're going to continue to feel like our healthcare is being ping-ponged back and forth, or tossed back and forth like a football, as you say. And I think, what this comes down to is recognizing what you just said, which is that as tempting as it is for the party in power to push for what they want, the next time we go through this debate, as we've done practically every decade, we should plan on going through it in a way that give us more what we as Americans deserve. And I'll try to define that just a little bit as we close. One of those things is that we do allow ourselves to have every American in the country with a regular source to care, access to a regular source of care. And you call that whatever you want. You call it universal coverage, you call it whatever you want. But we know, as we talked about earlier, that when Americans don't have a regular source of care, health care becomes the thing they never thought about until it becomes the only thing they think about because it overwhelms their life. Number two is what people, I think, talk about as the Jimmy Kimmel test. That if you're born with a child a month early, or you are born with your child gets cancer, or your spouse gets cancer, you don't have to worry about going bankrupt. You can just focus on getting better. Two common sense things that I think the vast majority of the American public believe in. So if we want to get there, but we want to do it in a sustainable way, we're going to have to do it in ways that are both economically sustainable. In other words, we should be able to pay for what I just described. And we have to do it in a way that's politically feasible. And that means that we have to demand of our politicians that they support these common sense ideas and these common sense principles regardless of party. And that means that the American public is going to have to shift in its thinking, as I think they are beginning to say, this is what matters to us, this is what we expect of you, and only when there is a greater consensus out in the real world will we start to be able to push the Congress and the Senate, which is very polarized, toward some sort of consensus. It's hard work. It's going to take years. It's not a quick fix, but it's something that we all have such an important rooting interest in that I think we're going to start to see some progress.
Excellent. Well, Andy, thanks so much for taking the time to talk to us, and this has been great. So thank you.
As always, great.
All right.
Thanks.
Yeah.